Good morning, and thank you very much for New World Medical for organizing the meeting, and also for Dr. Letnan to invite me to talk on this topic on hypertensive phase. Oops. Well, I go too fast, sorry about that. Can we go back? Well, hypertensive phase is a little hurdle you have to jump over. You have put the armat in there, and you are thrilled about the pressure that you do not have a low pressure phase, but then hypertensive phase can be common. It happens to be about 4 weeks after the implant of the device, and followed by a drop of the pressure and then go higher, sometimes even higher than before the surgery. When you present to the patient, it can be pretty alarming to the patient. And armat valve seems to have a little higher weight than the other devices. Certainly, hypertensive phase is not just applied to one device, but to all tube shunt. This is an ABC study and published data that I calculated. The ABC stands for armat versus bar-valve comparison study. Depends on how you define the hypertensive phase. Happens more to the armat, but happens also to the bar valve after the ligation or the occlusion open and they drop the pressure, and then followed by increasing of the intraocular pressure. So typically, when the pressure is high, then the knee-jerk response is to start the medication. So about a couple years ago, we thought about, should we start medication earlier, or is it some people doing this already? So we hypothesized that by starting medication to lower down the production of the aqueous, maybe we can decrease the weight, the magnitude, and the duration of the hypertensive phase. So we designed this study in a prospective way to look at early use of the therapy, whether we can lower down the pressure of the eye. In particular, patients using the FP7 model of the armat, the silicone armat. Okay, let's see. Let me see. The definition of the intraocular pressure increase is more than 21, according to the literature, followed by a drop of the pressure, not because of any occlusion or malfunctioning of the device. The timing of the therapy is difficult. That is the difficulty of the design. Now, we don't want to start it too early because we don't know whether that will be dropping the pressure too much, causing hypotony-related complication. Again, we don't want to have a control group that we have no treatment because that's unethical. Based on the literature, the opening or closing, actually the closing pressure of the silicone armat is around 7. That's a wide range. So we designed that maybe around more than 10, the pressure will start the treatment compared to a group that more than around 17, which is pretty much the typical time that you will start therapy. So we randomized the patients into 2 groups before the surgery. We call it the low intraocular pressure initiation group versus the moderate pressure initiation group. The division is 10 versus 17 millimeter mercury. Also, there are some patients that may be more troubling. They have more inflammatory reaction, like uveitic glaucoma or neovascular glaucoma. So we randomize the patient, also we stratify according to the glaucoma subtype. Can you play the video? It's important to show you how we do the surgery. Very briefly, it's less than a minute. I use lidocaine with epi, blow up the conjunctiva for hemostasis and also for the ease of dissection. And then we implant that, the plate, we make a radial incision. The exposure is the key for any surgery, not just for the armat implantation. I use a 7-O-proline to suture that in place, because 7-O-proline has a pawn, needle with no cutting on the side. The 22 gauge needles engaged the sclera 2 millimeter posterior to the limbus, and then you tunnel, you can basically see the metal, and so you can choose where you want to get closer to the iris or closer to the cornea, depends on the angular structure. And we use it's my computer, the power is poor so that the flow is not good. I usually don't do something like that. We use the split thickness half moon cornea to cover because it's very pleasing. Then we close it. One thing important is I used Helon to form the AC to make sure the pressure is firm enough to be around 30 before I end the surgery. Postoperatively, typically steroid, antibiotic, and use aqueous suppressants. It is important to protect the eye, so there's no limitation of using any medications to control the pressure. Well, we have make certain comparison. In order to understand the hypertensive phase, we compare patients with hypertensive phase versus no hypertensive phase. Now, we talk about that, we randomize patients into two groups. The one that has pressure higher than 10, we start the treatment, or is more than 17, we start the treatment. So that's a comparison. But as you have put implant in the eye or do any glaucoma surgery, you'll find out that it's not a cataract surgery. Your pressure can be low, can be high, can be all over the place. So it is actually quite difficult to randomize patients that way. In fact, it's the intention, so we randomize that preoperatively. But in reality, there's some patients that will start the medication before they have the hypertensive phase. And some patients, you end up starting the medication after the hypertensive phase. So we have to make one more comparison, and that is, what happens if we start the medication before the hypertensive phase, and what happens after the hypertensive phase? So let's look at all the three comparisons. So we published it in 2014 last year. We have 52 eyes in 50 patients because one patient randomized one eye to one group, the other eye to the other group. Let's look at the hypertensive phase. I'm going to draw your attention to the side, to the right-hand side, your right-hand side, the red numbers. The complication is not that high. The bottom over there, the hypertensive phase happens to be about 45%. I'm sorry, 40%. On the side, I cannot see the screen. So the pressure rise in those patients with hypertensive phase, the peak pressure can get up to, the mean is 30. The range can get up to 45. It happens to be about 4 weeks, which is 1 month after the implantation. And the mean lasts for 2 weeks. So in the past, people are saying that it will last forever, and not true. Some patients last forever. The majority of the patients, 90%, will have the hypertensive phase resolved, or the pressure come back down to less than 21 within a month. Now let's look at the first comparison, the patients with hypertensive phase versus the patient without hypertensive phase. We found that the patients with hypertensive phase do not as well as the other group, that pressure is higher and also at the end require more medication and a higher pressure in 1 year and later in 2 years. And they also require more surgery, additional surgery, because you need to control the pressure. Now let's look at our intention. The group that has a pressure more than 10, then we start medication versus more than 17. This is interesting because, they're almost the same. That in 1 year, 2 years, the pressure end up to be about the same. But then, if you look at the red line, which is the eye that has the pressure intentionally started, more than 7, after the pressure more than 17, you have a drop lower the pressure initially, and then a rise of pressure higher than the other group. What happened is, when we were waiting for the pressure to go up before we starting the treatment, because we limited by 17, we have a low pressure and keep on looking at that, and then all of a sudden it jump up. I think that's a typical experience that you have. You follow the patient, you follow the patient, you follow, and then you find out that in the next time you see the patient, the pressure will jump up 2 times, from the mid-teens all the way to 20-something. And that's exactly what happened when we wait, and in this scenario. This is the comparison that I talk about as important because there's a lot of variation of intraocular pressure after the tube shunts. You really cannot predict. And so we have some patients we start earlier, some patients we start later. The majority of the patients that we end up not starting the medication before the hypertensive phase end up to be in the moderate intraocular pressure initiation group, the one that we try to wait for the pressure to go higher before starting the medication. And if you wait long enough, then the pressure, the mean of that group, of that 12 patients, is 30, much higher than you expect, or want to. And this is important. Eventually, the pressure is still the same, but then in the first 4 months, you have to entertain a high pressure. So as a summary, hypertensive phase is about 45%, but if we start the medication early enough, maybe we can increase our bet. We cut it down, and the pressure will be lower. The pressure, if you wait and for the pressure to start before you start medication, it can get up to about 30. Compare the patients with hypertensive phase versus not, the one without the hypertensive phase has a better outcome eventually, and lower requirement of medication and surgery. And I think if you start early, we can lower down the weight, the duration, and the extent of the magnitude of the pressure rise during the hypertensive phase. But it has to be practical because of any study you have to apply to in the same context that we are talking about the FP7. So I cannot even generalize it to the S2 or other RMED model or other shunt. And we use a 22 gauge, a little bit bigger than maybe use 23 gauge needle. I use Helon to fill up the eye to the pressure around close to 30 in order to get a pressure of around 11 or 12 the next day. Now, a lot of people ask me what happens if the pressure is low in the first day. That's okay, you wait, okay? You wait for about a week, and at that time, all the Helons is gone, and you have an aqueous in the eye, you know what's the pressure, and you decide. But I think the most important thing I want to say is it can be started, and starting that is not going to cause any problem. And thank you very much.